Hello, everyone. Thank you for joining us today for our Gutsy Learning Series webinar on the topic of gut mucosal healing and new therapies for IBD. My name is Sarah Gandaharian, and I am the Manager of Patient Programs and Evaluation at Crohn's and Colitis Canada. Before we get started with the webinar, we're going to run through some technical logistics. First off, this event is being offered in English and French audio. If you'd like to listen in French, please select the interpretation icon. It's a globe icon that you can find in your Zoom menu bar. Please select French as the language. And if you'd like to ask a question, please use the Q&A box found also in the webinar menu bar. If you raise your hand, unfortunately, we will not be able to unmute you. But if you'd like to ask a question at any point, please use that Q&A and we'll pass it along for the Q&A period later on. And if you experience any other sorts of technical problems during the event, please try refreshing your website browser or relaunching the Zoom webinar. You can also, again, comment in the Q&A box for any troubleshooting issues, and we'll follow up with you directly there. I would also like to begin by recognizing the history and heritage of the Indigenous people of Canada. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. By acknowledging their traditional territories, we show respect to the Indigenous communities and promote reconciliation. And I'd also like to provide a disclaimer. Just a reminder, for those of you who have joined us before in the past, and maybe for those that may be joining us for the first time, the materials and the information that you receive in the presentation this evening is for educational purposes only. They're of general value and they may not apply to specific medical situations. These online resources are not a substitute for the personalized judgment and care of a trained healthcare professional. So we'll do our best to answer your questions this evening, again, during the Q&A period. And if we are unable to, because of the nature of the question, we'll let you know to follow up with your healthcare provider directly. And I'd like to now move over to sharing our promise with you. Again, maybe some of you who are joining us, from other webinars in the past, you may be familiar, but Crohn's and Colitis Canada's promise is to find a cure for those people that are living with Crohn's disease and ulcerative colitis, and to improve quality of life. Thank you so much again for your interest in being here this evening and your interest in Crohn's and Colitis Canada initiatives. And if you're as ready as us to make a difference in the lives of those affected by Crohn's disease and ulcerative colitis, then please mark your calendars for our upcoming Gutsy Walk event happening across Canada on Sunday, June 4th. This is an amazing opportunity to see the Crohn's and Colitis Canada community come to life and to show your support for a great cause. Whether you choose to create a team or walk individually with your family and friends, your participation will help raise funds for research and support services and make a real impact in the lives of people that are affected by IBD. You can register to participate or donate to support our mission at gutsywalk.ca. You can also scan the QR codes that are using your phone that are up on the screen to be taken to the website. And, if you or someone is affected by Crohn's disease or ulcerative colitis, we also encourage you to check out our bi-weekly Gutsy support events. These are virtual sessions that provide an opportunity to connect and meet with others that know what it's like to live with Crohn's disease or colitis and get advice and practical strategies to cope with the everyday challenges. And so we have several upcoming sessions available in both English and in French, including April 26th, May 10th, May 23rd, May 16th, and June 6th. If you visit the website, www.crohnsandcolitis.ca/Gutsy support, or if you scan the QR code on the screen there, you'll be taken to all the upcoming events. And more information on how to register is on the website. And in addition to this evening's Gutsy Learning Series, we've also have a few other events coming up in May and then later in September. So if you're interested in learning more about natural or complementary therapies for IBD or dietary therapies for IBD, I would certainly encourage you to attend. If you visit our website, crohnsandcolitis.ca/GLS, the information on how to register is there. And again, you can also scan the QR code on the screen. And the information and the recording from today and all of our Gutsy Learning Series presentations are accessible on that website, crohnsandcolitis.ca/GLS, or on our YouTube channel at Get Gutsy. And you'll be able to access the recording of this presentation tomorrow, and it will also be emailed to you. And again, a quick final reminder that if you'd like to listen to today's webinar in French, please select the interpretation icon in the Zoom menu bar and select French language. And now we're ready to get started with the presentation. And I'm absolutely thrilled to introduce you to this evening's speaker, Dr. Remo Panaccione, who is a world-renowned expert in the field of IBD. And so we are really grateful for him making time to be here with everybody to share some really interesting information about new and emerging therapies. Dr. Remo Panaccione is the Assistant Dean of the Medical Doctor Admissions at the University of Calgary and is a professor within the Faculty of Medicine at the Cumming School of Medicine. He is also a gastroenterologist and serves as Director of the Inflammatory Bowel Disease and Director of Research of the Division of Gastroenterology and Hepatology. Dr. Panaccione was the recipient of the Crohn's and Colitis Canada Physician of the Year Award in 2020. He is also a lead scientist for Crohn's and Colitis Canada's Promoting Access and Care through Centers of Excellence, also known as PACE network, and is a member of our COVID-19 task force. He has been recognized as a Clarivet Research Scholar for being cited in the top 1% of researchers cited in the world from 2020 to 2023. Dr. Panaccione is the author of over 500 peer-reviewed articles, including publications in journals such as the New England Journal of Medicine and Nature. His research interests lie in the fields of advanced therapies, biological therapy, and the delivery of care. We are honored and thankful to have him here this evening to join us and share his expertise. Thank you, Dr. Panaccione, and please take it away.
Oops. So thanks, Sarah, for the kind introduction. I'll just share my screen here. So, out of everything that we do in our lives, I think that one of the nicest things that we do is obviously take care of patients. I think that's the reason that most of us went into medicine. And so, although I think my sort of professional career has diversified over time, there's no substitution for what I call my Monday IBD clinic, because certainly the patients that we see every Monday are really the inspiration for us to do better, not only as clinicians and researchers. The second thing that I like about Monday is really the opportunity to educate patients, because patients who are educated, I believe, are empowered. And hopefully tonight you'll get some education, and that education will allow you to empower yourself and go forward as you continue your journey or the journey of a loved one in anyone who suffers from inflammatory bowel disease. So today, what I've been asked by CCC to discuss is really this concept of gut mucosal healing and how it relates not only to the evolution of this concept, but new therapies for inflammatory bowel disease. And for any of you who've heard me speak before, I'm a clinical trialist. What I do is try to develop new therapies with my global colleagues to make the lives of patients better. And certainly we're in a very, very sort of what I would call the golden era of IBD therapeutics. There's many, many new therapies that are just being released now or are in the horizon. And I think that this just bodes well for everyone. So this is what I'm going to do. I'm going to teach you what the gut or intestinal mucosa is. We'll talk a little bit about how IBD damages the mucosa, and then transition into, why mucosal healing is important for you as an individual patient, and what are some of the strategies that we can employ to promote mucosal healing, and then talk to you about some of these new and exciting therapies. And then we'll end off by taking some questions from the audience. So we're going to start with a polling question that CCC put up. So the first question is, how would you rate your current knowledge of the medications that are used to treat Crohn's disease and ulcerative colitis? So 0 would be no knowledge at all the way up to 10 which is very knowledgeable. Okay, so it's a little bit all over the place. So there's about maybe 20 to 40% of people are quite knowledgeable, but some others are less so. And, just to anchor us, I think it's really, really important as an individual patient to be able to, again, gather as much knowledge, especially when it comes to the medications, and have that ongoing dialogue with your healthcare professional so that you have as much knowledge as possible. So let's answer that first question. So what is the gut mucosal lining? Well, in simple terms, it's really the lining of your gut or your intestine. That's what the mucosa is. And it's really the lining from your gums all the way down to your bum. There's other linings that are called mucosa in the body. They reside in the respiratory tract or genitourinary tract. But obviously today we're going to focus on the gut mucosa. And so this is a sort of an anatomic diagram, and obviously you don't need to know all of the terms here, but just to suffice that the mucosa itself has multiple layers. It has an epithelium that's made out of cells, and that's really what we see when we do, for example, a colonoscopy. Then there's another layer called the lamina propria, and then there's this very, very thin muscle layer that is in the mucosa as well, and it's more of a microscopic muscle layer. The mucosa itself is just one of multiple linings or multiple layers in the bowel. You have a layer below that, which is called the submucosa, and then you have a muscle layer below the submucosa, and then you have what we call the wrapping of the intestine or the serosa. And so when we look with endoscopy, what we're seeing is only the inside. When you have other tests such as ultrasound or CT scans or MRI, they can see all of the layers of the bowel beside the mucosa. And we'll touch on that a little later. Because the mucosa, which is that inner lining, is right next to the lumen or the hole in your bowel where all the contents are, it has a lot of important functions, and we're going to review some of those important functions. So we can, on the left is that cartoon that I just showed, and on the right-hand side is what it looks like when we take either biopsy specimens, or in this case, this is a surgical specimen. But in the top corner on the right is really when we take a biopsy, what we can see. If I have, I'm going to put my pointer on here, my laser pointer. If you look right up here, what you can see is this sort of these little squares are actually the first cells that you can see, and you can see, and then we can see the deeper layers of the mucosa when we take tissue biopsies. So one of the questions that we get in clinical practice often is, oh, why are you taking biopsies? And many times we're taking biopsies to see if we can see inflammation within the biopsies, because sometimes inflammation can be microscopic and not visible to the eye through the endoscope. So I want you to remember that term inflammation because it's going to come up a little later in the talk as well. As I said, the mucosa has a lot of important functions, and you don't need to be a physician to appreciate how important these functions are to your day-to-day life. So it has a barrier function. So it serves almost like your skin, as a barrier to the entry of harmful substances, what we call antigens that can stimulate your immune system, or organisms. So similar to your skin, you can imagine if there was a break in your skin, you would be at increased risk of developing infections, or the deeper layers of your skin would be at risk for being damaged. So that barrier function is very, very important, and we'll talk about that. Sometimes, if you think about in lay terms, when we talk about a leaky gut, right, that really describes that concept of that barrier breaking down when your mucosa is injured. It also has a very, very important immunologic function. So the cells that make up the layers of the mucosa are truly the first line of defense of the body in our immune system. So anything that's in your GI tract, whether it be bacteria, food antigen, the results of smoking, medications, anything that's in your gut is really sensed by this immune system that makes up the mucosa. It also has a secretory function. So depending where you are in the gut, the mucosa secretes digestive enzymes and local antibodies to help sort of keep bacteria at bay. Those digestive enzymes and other things are important for the digestion of the food that you're eating every day. So if that secretory function is not working, you can't digest some of the contents that you're taking in every day. And after you digest them, because of the secretory factors from the mucosa, it has this absorptive factor. So it absorbs those breakdown products of digestion, whether it be carbs, fat, protein, water, vitamins, minerals, and electrolytes. So, if you take those four key functions of the mucosa, you can see that if the mucosa is not functioning properly, there could be a price to pay. Now, the other thing that's important is I did talk a little bit about the barrier function, and the barrier function comes in different aspects. So there's a chemical barrier, which is really the mucosa that secretes things that will fend off, for example, bacteria, etc. There's that physical barrier, so it needs to be intact physically, just like the skin or the wall of your house, right? It needs to be intact to keep what needs to be outside out and to keep what's inside in. And then that immunological barrier. More and more research outside of IBD is we think that barrier function is so important, not only to inflammatory bowel disease, but a host of other diseases. So now we're starting to recognize that the breakdown of the mucosa and that barrier function may lead to increased risks of things such as diabetes, heart disease, even lung disease, and more recently, even some degenerative brain diseases like Parkinson's. So again, the mucosa is so very, very, very important to health, wellness, and when it breaks down, it can lead to several diseases. So how does IBD damage the mucosa? And this is important to understand because it then segues into why we use certain therapies to try to control inflammation, control the immune system, and by that way, repair the mucosa. So you've probably seen this type of slide in one of the talks if you've attended before. If we think about what makes up inflammatory or what contributes to what we call the pathogenesis or what causes inflammatory bowel disease, we know that there's a genetic component and there's multiple genes that have been identified, but to our knowledge, that probably makes up just a small percentage. There's an environmental component. There's a whole bunch of environmental things such as smoking, diet, medications that probably play a role. And then that interaction between the genetics and the environment can lead to breakdown of the intestinal barrier that I've already talked about. And then once that happens and you have that first line of defense that's gone, then your immune system ends up being stimulated and you get this imbalance of the immune system. The immune system then causes inflammation. That inflammation further damages the mucosa and it ends up being a vicious circle. And so later on, when we talk about therapy, you can imagine that we can't do anything about an individual's genetics, right? We don't know for a specific individual what that environmental trigger or that environmental factor may be that may be driving their inflammatory bowel disease. And once that intestinal barrier is broken and the immune system is stimulated to cause inflammation, think about inflammation almost like a fire, sort of then perpetuating, and the mucosa being such as a forest, you start burning down the forest and you get this vicious cycle. And so when we think about trying to control that, we try to control the immune system or affect the immune system so we can break that cycle. And in that way, the mucosa can repair itself as we try to put out that fire. And that's why when we talk about a whole variety of therapies, and individuals often ask, oh, well, what about diet, et cetera? The diet right now probably sits more on that environmental factor. Can we change the things that start maybe driving it? But that's why, if you look at all of the studies that are available in adult patients, diet alone hasn't really made a big impact because it doesn't turn off that forest fire per se. Now, this is something that this is how complicated it is. I'm not going to walk you through this, but there's several aspects of the immune system that are shown in this cartoon that we can target. And we're going to talk about some of these drugs later on. And this is just a cartoon just showing the steps that I already talked about. So we'll skip over that. So I'm going to show you some images. Some of you may have seen your endoscopic images before. Some of you may even have been awake for your endoscopic procedures and been able to see this live. But I just want to give some examples of what we see and what the mucosa should look like, or the bowel should look like. So this is the way we see inflammatory bowel disease. We see you as a patient with symptoms, but then we go in and we want to look at the bowel. And in a normal bowel, this is what it should look like. So there's a couple of highlights here. You can see it's nice and smooth, it's shiny. You can see those little red lines that look like a tree. Those are the blood vessels. And we should be able to pick those blood vessels up and trace them along if your bowel is nice and healthy. Unfortunately, when you develop inflammatory bowel disease, you can either look like the image on the left-hand side here, which shows that now you can see all of those blood vessels. We can't see them anymore. You can hopefully appreciate that it's no longer sort of smooth. It looks bumpy and then swollen. And the white areas are the bowel actually weeping or creating what we call exudate. And there's some ulceration here. On the right-hand side here, what you can see is that these long sort of defects in the bowel and damage to the bowel. These are ulcers that we typically see in patients with Crohn's disease. So on the right-hand side is ulcerative colitis. And on the left-hand side is ulcerative disease. And hopefully we can appreciate that your bowel can't stay and look like this for a long period of time. Because it's not supposed to look like this. And the one thing that always perplexes us and is a very important teaching point. So the first teaching point that I want you to take home today is that you can be completely asymptomatic. Your symptoms can be completely normal. And if you have IBD, your bowel can still look like this. And I know many of you may be scratching your head and saying, that's impossible. How can it look this sort of angry and damaged and I can have no symptoms? We know that in about 40 to 50% of the cases, that's the case. Patients come in, they have no symptoms to suggest that their disease is active. But if we looked in, it looks exactly like that. So hold on to that thought. But remember, your symptoms are not always telling us the entire story if you have damage to your mucosa and vis-a-vis if your IBD is active. So this is an image that most IBD patients don't want to see, which is these are images of our endoscopic images, instruments, and certainly this allows us to see the mucosa. So if you want to know what your mucosa looks like, what is the gold standard to see if your mucosa is healthy? The gold standard is to do an endoscopic evaluation. Now, that doesn't mean that you need to really know, right? Does that mean that you need an endoscopy 3 or 4 times a year? Absolutely not, right? So the second thing that I want you to remember is there are other ways other than us taking a look in that can give us an idea if your mucosa is healthy or not. Okay, so first one, symptoms don't tell us if your mucosa is healthy. Second one, there are other things that we can do to tell if your mucosa is healthy. And so why is having therapies or trying to target gut mucosal healing important? Well, I think many of you would probably sort of guess the first thing that I'm going to say. If the mucosa has all of these important functions, and those functions are disrupted, if the mucosa is sick or damaged, you can imagine that the first thing we want to do is we want the mucosa itself to heal so that we can restore these functions, whether it's the barrier function, the immunologic function, the secretory function, or the absorptive function. And some of these functions are important in stimulating the symptoms that you get. So either that, the absorptive function, you can imagine, can't absorb your nutrients, you're going to lose weight because your mucosa is damaged, you can't absorb. The secretory function sometimes is related to the symptoms of diarrhea on top of what you get with the inflammation. But besides that really simple concept of let's get the mucosa healthy so it can perform all its important duties and functions, we now have evidence over time, evidence from multiple sources that if we can take an individual patient and take the sick mucosa and heal it, that's associated with many positive benefits for patients. We know that it reduces hospitalizations when we do it in Crohn's disease. It reduces your chance of proceeding to surgery, whether you have Crohn's disease or ulcerative colitis. It reduces your chance of actually developing a flare in the future. So it's almost like this crystal ball. If I can get your mucosa better, I can reduce the number of flares you have. And it increases your chance to stay in clinical remission, symptomatic clinical remission, over time. And because of that, it actually reduces the impact that that your disease has on your work and leisure activities. The mucosa is very forgiving, but it can only forgive so much. And so the way I explain it to my patients in my practice, if you think about the damage to the mucosa, I'll go back to the skin. Whenever you have a flare of disease or inflammation, it's like cutting your skin. And if you've had one flare and we can put you back in remission, we can heal your mucosa, it's like having that like one cut on your skin. Most of us will heal pretty well. You might not even see the scar, right? But you can imagine if in that same area, because IBD usually comes back in the same area, if you damage that area repeatedly, like cutting your skin in the same area, in the same place, what happens over time is that area gets damaged and scarred. And that's what leads to what we call the progressive nature of the disease. And so we know if we can heal the mucosa and it's not damaged for a long period of time, we can decrease the damage that's done to the bowel. And so one of the biggest things is in the way we treat inflammatory bowel disease is this recognition that we need to try to target the mucosa and heal the mucosa, or achieve, as you can see in red here, mucosal healing, because it's that target or that goal, and we'll talk about that in a little while, that really leads to what we call long-term disease modification. It's really the only thing that has been shown now that can lead to all of those positive effects. And that's why it's important for you to be educated regarding this. And what I do in my own clinical practice is I try to use analogies, and I'm going to bring some of those analogies to you today. So there's other chronic diseases where there's this disconnect between patients having symptoms from their disease and patients having control of their disease. So diabetes is a good example. So in patients with diabetes, many patients with diabetes don't have physical symptoms, after they've been diagnosed, right? But endocrinologists or your family doctor, they don't look at your diabetes and ask you about symptoms, right? They have a target, right? They know that if this, and it's on this slide here, if they can get your diabetes controlled by this target of what we call a hemoglobin A1C, that's related with decreased complications associated with diabetes. It's the same thing when you have high blood pressure. If any of you have been diagnosed with high blood pressure, it's usually because you go into your family doctor's office, they measure your blood pressure and they go, oh, your blood pressure is high. You probably haven't had any symptoms. But if they put you on medication, what do? They don't ask you about symptoms of your high blood pressure. They actually put up that blood pressure cuff again, and they want that number to be in a certain range. And the reason is because if you have that number in a certain range, it actually decreases the complications that you can have from having high blood pressure. So many years ago, we asked ourselves, what should that target be in inflammatory bowel disease? And most of you have already probably guessed, or else you wouldn't be here. And that target is mucosal healing. And so in those other diseases, tight control and making sure that you're within those parameters has led to benefits, as I've already outlined. And it has done so, as already outlined, in inflammatory bowel disease. So the third thing that I want you to remember is that if you are interested in improving your long-term outcomes in living with inflammatory bowel disease, it's important that one of your goals should be to try to achieve mucosal healing. So we sort of look at the disease a little bit different from a clinician and for a patient perspective. But in the bottom here is I think that where we align in what is important for patients, which is getting you better quickly, getting your symptom under control, making sure we can do that over the long term with safe medications, and using drugs that we have a good benefit risk profile. But where there's the disconnect, unless you have the education, is trying to actually achieve this goal of mucosal healing. And so, I always say I've done my job when patients actually come and start asking, do we need to look inside again to see if my disease is under control, even when they feel well? That tells me that I've actually done the proper education. Or they ask me about what I'm going to talk to you about is surrogate markers. Are there markers that suggest that maybe my disease is not under control? Okay. So it's really important to remember that we've entered an era that we're going from symptom control, which is always going to be very important. For you as an IBD patient, the way you relate to your disease and the way the disease affects you on a daily basis, for most of you, is the presence or absence of symptoms. So we'll never, ever, ever lose sight of that. but we have entered an era of disease control. And that disease control is mucosal healing. So I'm going to throw around some terms here. So because we're going to transition into some data and some evidence. Okay, so endpoints are what I measure, or what we measure as an academic community when we try to get drugs approved for you through regulatory authorities. They have strict definitions of and at strict time points on when we need to achieve it. From that evolved what we call targets, like our treatment targets within clinical practice. And we'll talk a little bit about that. So, and those targets often align with those endpoints. But most important when I'm in practice is treatment goals. And treatment goals are both physician and patient defined. But, the master of treatment goals is the patient themselves. And so it's important for you to make sure that your healthcare provider understands what your goals are, right? Obviously, you've already heard me say, in my perfect world of clinical medicine, I would want educate patients to make sure that one of their goals is to achieve mucosal healing. But A, not all of our medications do that at a high rate. And B, not all patients sort of have been educated or believe in this concept of mucosal healing. So how's our understanding of mucosal healing changed the way we treat IBD? So for those of you who've had inflammatory bowel disease for a long period of time, you may have seen a shift in how your gastroenterologist or your healthcare provider approaches your Crohn's disease or ulcerative colitis. And the number one thing that you've probably noticed is you're probably getting a lot more testing and monitoring of your disease. And the reason that that's happening is truly because of the value and the importance we put on mucosal healing. And that importance has evolved over time. And this is just an illustration of what we've come to know. So back in the early 1990s, because of the medication that we had available to us, therapeutic strategies and how we treated patients had nothing to do with what the bowel looked like. So all of you are probably, or most of you are probably familiar with prednisone, which when it works really rapidly. It can relieve your symptoms. You're like, oh, and we won't talk about some of the pitfalls of long-term prednisone, but prednisone is very, very powerful at controlling symptoms. The reason that we thought this way in the 1990s is if we looked in patients who felt well after prednisone, it didn't do a lot to heal their mucosa. So we didn't even bother looking, right? About 30 years ago, we started saying, okay, well, there's a way we can measure the, mucosal healing. And then in the mid 1990s, then towards the later 1990s, we started developing, and drugs were available that could achieve mucosal healing. So we became excited. It's like, if you ask any gastroenterologist, one of their sort of biggest scientific memories was actually the cover of one of our main journals, where they showed a patient who was a 14-year-old girl who had Crohn's disease and had a picture very, very similar to what I showed earlier. And then right beside it, after 3 months of therapy, was this completely normal bowel, right? And that excited us because finally we had a drug or drug therapy that could make the bowel look better. And because of that, and because of multiple other therapies that have been developed since that time, mucosal healing has become very desirable. And if you look at our guidelines and recommendations, mucosal healing has had a spotlight on it ever since we've had these drugs. So these treatment goals have evolved over time. And again, symptomatic improvement will always be important, getting you into remission, feeling normal without steroids. But in ulcerative colitis, we look in and we have this sort of treatment target that we want of mucosal healing. And similarly in Crohn's disease, for the reasons that I said, because we know if we can achieve this, we will change your natural history. And this is just other guidelines. And it can take time, just like healing sort of a wound on your skin. If it's been damaged, it can take time. So this is what we call the STRIDE 2 consensus. This is expert opinion from thought leaders around the world that we developed initially back in 2015, and then we've just updated it. And it sort of is a way for us to teach our colleagues that when you start a new therapy, you need to have sort of immediate targets of getting patients better. Then we're going to talk about biomarkers in a second. You need to normalize their blood work and their biomarkers. But ultimately, within that first year, and the long-term outcome should be this endoscopic healing or mucosal healing. And this has made it into, these are just European guidelines. So any guideline that you see will end up mentioning this. So let's go back to, here we go. Here's a gastroenterologist. He just wants to stick a scope up me again. But it's not that. As I said, I promised, right? There are other ways that we can ascertain whether you're achieving mucosal healing. And so the next thing I want you to remember is that there are tests that you can do every 3 months to 6 months that will give us an idea if we're controlling inflammation, and vis-a-vis give us an idea if you're achieving mucosal healing. And the two tests that we normally use, and you should be familiar with, number one is called a C-reactive protein, which is a blood test that can be done when you get your regular blood work, and it is a marker of inflammation. And the other one is a stool test. So not as good as, and not something that everyone wants to do, but this fecal calprotectin test actually is a very powerful tool that tells us if we have control of your disease or not. It's like that hemoglobin A1C. So when patients in my practice are flaring or sick, we will do this every 3 months for the first year. And even when you're stable, you can do it every 6 months. And we know that there's two things. Not only does it tell us whether or not your inflammation is controlled, but if we use it in conjunction with the medical therapies that we have, you can use it as a signpost to increase the rates of mucosal healing. And this is a study that we published several years ago where we divided patients, one group into just patients that we would increase their or introduce and increase their therapy only when they had symptoms and or they required steroids, and another group that we also did these blood and stool tests on. And if those were abnormal, regardless if they had symptoms, we would escalate their therapy. And what that we showed is that by doing what we call the biomarkers, we could increase the rates of mucosal healing. And what did that translate into long term? Not surprisingly, when we looked at it, if we could push the rates of mucosal healing up, those patients who achieved mucosal healing, if we looked at them 2 to 5 years later, it reduced their chance of having a major adverse outcome by 60% if they were in endoscopic remission or mucosal healing. And if they were symptomatic and better and had endoscopic remission, we could reduce that by 80%. So, and that's hospitalization, surgery, or complications. So this fecal calprotectin testing is important. So the next thing I want you to remember is, poop tests are good, right? They're done for a reason. You should know the number, right? And so here's some numbers. So anything over 250 usually is associated with active inflammation, and you need to do something about that. There's other things that can cause over 250. You should talk to your healthcare provider, but it should be a trigger to, I need to do something. 1 to 250 is more of a sort of gray zone. It could be, I need another test in 3 months. Let's see what the trend is. Maybe I need to do another test, an ultrasound, a scope. But if you're below 100, the chance that you have active disease is pretty low. So I'll just skip ahead for monitoring. So how can we promote mucosal healing? Well, let's go to the poll. So which class of medications are you taking now? Let me see. I like when this list gets longer and longer every year. Makes me happy. Okay. Okay, a lot of patients on biologic therapy, over half. Some patients still on our traditional immunomodulators, and some patients on 5-ASA. Okay. And I like that not many patients are on steroids. So I'm going to skip over a couple things, except for one of the things that's really, really important is this concept of what we can do early in your disease versus late in your disease. So early in your disease, before you've had repeated cycles of bowel of inflammation that can cause damage, we can achieve everything. We can make you symptomatically better. We can have higher rates of mucosal healing. So this concept of this window of opportunity where we treat you early is super, super important. In later disease, and when we say that, meaning if you've already developed a complication or you've already had surgery, sometimes there's only so much we can do. Number one is the mucosal healing rates are lower, even if you use the same drug. And number two is, some of you may have experienced this if you have Crohn's disease, or even if you've had ulcerative colitis in a pouch, is that you have residual symptoms because of the surgery. So we can maybe never get you back into being completely normal as far as symptomatic remission is concerned. So what we would like to do ideally is we would like to take you when you're active. We'd like to do a series of tests that are non-invasive. And if those tests are abnormal, we'd like to talk to you about either intensifying or transitioning your therapy to something that will control inflammation and ultimately achieve mucosal healing. So there's three really, really important things. And your physician hopefully will discuss this with you. The one is early intervention. Use highly effective therapies that are associated with mucosal healing as early as possible in the disease course. So early intervention. And that's why I'm a big believer in, and that's one thing that I'm a big believer in. I'm a big believer of, when we talk about therapies with patients and they're like, well, maybe I'll do it in 2, 3, 4, 5, 6 months. I usually say, you know what, if we're going to make this a decision, we want to make it now, right? This is, again, the forest fire, right? And the analogy, and it's burning, right? It's like, I'm going to wait 2 days before I actually put something on the forest fire. Well, another 5, 10, or 15 acres have burned down. So that early intervention, really important. This concept of treat to target, which I haven't really articulated, but that is aiming for mucosal healing as your target. In this tight control, like the monitoring with the blood tests and the stool, that's the way that we can actually get to the highest levels of mucosal healing. And as I said, using drugs that have shown to do this. So this is really the new road, right? So we characterize you, tell you whether or not we think that your disease is going to progress. We talk to you, try to set common goals and decide on what treatment we're going to start with to achieve those goals. We monitor your response to therapy, and then we adjust as needed. And the one thing that is really, really important as we transition into therapy is the one thing that I can never tell a patient is what the right drug is for the individual patient. Even though I have all of this data in front of me, the right drug for an individual patient is the drug that's going to work, get your symptoms better, get you into mucosal healing, that you're happy taking for the long term, and is giving you no side effects. And when we have that discussion about deciding treatment, I have no crystal ball that tells me for you as an individual patient what that drug is going to be. So that's frustrating for us as physicians. And I can only imagine how frustrating that must be for patients. So we need to do better. Okay. I'm going to transition now into a little bit about therapy, and CCC has asked me to talk about drug development and the authorization process in Canada, which I think is really important for two reasons. If you have never been exposed to this information, it might give you an idea of how long it takes to not only develop a drug, but the steps that go into it, especially when it comes to things such as safety. And the other part of this, because we'll show you 6 stages, is your opportunity to be advocates sometimes, because even after we've successfully, developed a drug and shown that it works, there's multiple steps after that take a long period of time in Canada, which personally I believe sometimes is unfair with patients with chronic illness. So the first stage is really the discovery phase. So this happens with people who are much smarter than I am, who, that tangled mess of a cartoon that I showed you with all of those arrows and everything, they look at sort of different targets within the immune system and say, you know what, if we could develop a therapy that targets that part, perhaps that would work. So with that, they develop and identify different substances that may be used to treat a certain disease. And when they're developing these therapies, they look for not only what we call preclinical activity, but they're thinking about, is there anything that by introducing this into humans that would cause toxicity or problems, right? So that's the first thing. And a lot of that type of research happens, and drugs never get to what I'll show you is the next stage. Once they found something that's promising or a combination of compounds, they'll determine whether further research is needed to actually develop a drug or a therapeutic, which brings us to stage 2, where once that happens, so you go from the theory to developing a therapy. These therapies are usually tested on animals. In IBD, that's usually mice, or particular cell systems to determine its benefit and risks, even before any humans are exposed. If at that stage, it's like we've went from theory, we've now gone from theory into an animal, this looks like it has promise, then researchers can submit to what we call regulatory authorities, such as Health Canada, to conduct human clinical trials. The next phase is actually the clinical trial phase. And in the clinical trial phase, there's actually 4 different phases within clinical trials. Phase 1 is where the candidate drug or therapy is tested on a very small group of healthy individuals to determine if there's any toxicity. And this is usually done in what we call a multiple dose escalation study. So a little bit of the drug, then a little bit more and a little bit more to where we think there's a therapeutic effect. And so this is always done in what we call healthy controls. If it shows that there's no safety or toxicity concerns in the healthy controls, then it's introduced into patients who have the disease of interest. And in that what we call phase 2 studies, those studies are what we call dose ranging studies. So now it's about making sure that in phase 1, you've gone up to an acceptable level of tolerance. And then in phase 2 is to try to determine what is the best dose to control the disease. And so once a proper dose is identified, then it goes into phase 3, which is the confirmatory testing of efficacy and safety in a very large group of patients with the disease. And it's those phase 3 studies that lead to the approval of a therapy. And so in inflammatory bowel disease, to have a therapy approved, you have to go through all of these stages. and you need 2 induction studies, which are, for lack of a better word, 2 studies that shows that the therapy can get patients better. And you typically, traditionally, it was symptomatic. It's changed more recently. And 1 study of, can it keep you better? So 2 get you better studies, 1 keep you better. And then there's also phase 4 studies, and these are usually done after a drug is approved. They're called post-marketing studies, and they collect data on larger populations of patients, really to look for very, very rare side effects and to get better information on the risks and the benefits. So here's a question for you. How long do you think it takes Health Canada's drug review and decision process at most for approval or refusal? So this is a drug, it shows promise, it's been positive in the phase 3 trials, looks like it's going to make an impact on patients with the disease of interest. Okay, well, there's a lot of skeptics here, and so it's not quite 5 years, but it's between 1 and 2 years. And so, which I still think, in certain diseases, that's a long period of time to actually be reviewing a drug. Now, that's just at Health Canada. So we've done the phase 3 trial. It's been submitted to Health Canada. Now we're waiting 1 to 2 years as Health Canada can approve the drug. So let's say the drug is approved. When the drug company submits a drug establishment license, or what we call an NDS, for review, there's pre-submission meetings. If it's a breakthrough drug, that you can request a fast track review. That usually doesn't happen. And like I said, it takes about 1 to 2 years for Health Canada to review these files. Now, after a drug is approved, you can see some stage 4. Then you need to decide how the drug is going to be released to the public, and how the drug will be paid for by different provinces. So usually when a drug is approved by Health Canada, what we call a notice of compliance, most private payers, so private drug insurers, will pick up the drug pretty quickly. But if you're on a provincial plan, so you don't have an employer who has a private drug company, this has to go through another process. So this is where there's a disconnect, where patients who have private insurance can get drugs right away. But if you're on a provincial drug plan, you're going to have to wait beyond those 1 to 2 years. And this really is about a negotiation between the manufacturers of these therapies and the provinces on what the provinces are willing to pay on your behalf for a particular drug. And this has several stages as well. And so, how long do you think it takes before, if I showed you new data today, how long do you think it takes before I could actually prescribe the drug? Okay. Yeah, it depends on a lot of factors. And I brought up one of those factors, whether you have private insurance, where it could be immediately or within a few weeks, compared to if you have public insurance. And then there's this last stage where it's up to the drug company to make sure that the medication is used correctly and approved. This is monitored to make sure there's no false advertising. Health Canada monitors any reports after the drug is released to make sure that there's no untoward drug reactions. And so there's a lot of regulation around that. So it's not like a drug company can just go out there and say anything that they want. The only thing that they can say to prescribers, and here we don't have direct to consumers, but is what Health Canada has outlined in what we call their label. So with that, as I said, there's some new and exciting therapies that have just been released or will be released. And I'm going to focus on 2 of them this evening. So the first thing I want to share with you is across the top of this is Crohn's disease. Across the top here are different drugs that are on the market, all except for the last column that are including the last column, which is the newest drug. And on the far left-hand side here is how they were approved by the health authorities. And the reason that I'm highlighting this is most of the drugs that are out there, Remicade and its biosimilars, Humira and its biosimilars, Entyvio and Stelara, all of them were approved based on whether they could get you better symptomatically, or patients better symptomatically. And, your question should be, well, Dr. Panaccione, I thought mucosal healing was important. It is important, but it's taken a while for the regulatory agencies to recognize the importance of that. And when we talk about these new therapies, risankizumab, which is now available in Canada, called Skyrizi, it was the first therapy that not only had to be approved, not only had to make patients symptomatically better, but it needed to prove that it could achieve mucosal healing. So the uniqueness of that is the bar by which this drug was approved is higher than any bar that's been put before any other therapies, which means that in order to achieve that, the patients that went into this trial, they all had damaged mucosa to begin with. And now we know the true potential of the drug therapies we have. And this is similar in ulcerative colitis, where starting about, I'd say 10 years ago, we started, as opposed to Crohn's disease, which is more recently, where we've looked at mucosal healing. That doesn't mean that the drugs that are available, and here I'm showing you Humira on the left and Stelara on the right, don't achieve mucosal healing. They do in about a quarter of patients for Humira or biosimilars of Humira, because we think that would be the same. But a little less, with Stelara. These are indirect comparisons. When you do a direct head-to-head study, they look about the same. And the definition until recently has been a little different. So you can see the mucosal healing rates of the different trials that we've done is all over the place, but generally is in the 25% to 30%. Now, we've entered into this new era where, because of how we understand the immune system, our therapies have become more and more targeted. They're almost like, I use the analogy of a smart bomb, where it's really guided to one area of the immune system. And why is that important to develop some therapies like that? Because the more targeted the therapy is, and we know the more we're confident that it will achieve our targets, hopefully goals. And the other thing that it'll do is hopefully have less side effects. There's also this desire, because a lot of the newer medications have been either intravenous, given through an IV, or injectables, to develop more targeted therapies that are pills. And we'll talk about one of those tonight. So this is one of, I think, the biggest breakthroughs in immune-mediated disease, not only IBD, is before we thought that the immune system across immune-mediated diseases like skin diseases, joint diseases, and IBD were very similar. But again, people much smarter than me have recognized that in IBD and the skin, one of the driving factors is this, what we call interleukin 23. And that it's pivotal and central to driving the immune response and and there's this beautiful paper, not that we'd ever expect you to read this, in 2021 that describes this. And this is part of unraveling that sort of spaghetti diagram with all the arrows and all of the all of these different immune cells. And you can see that at multiple levels here that I've circled is this IL-23 or interleukin-23 that plays a pivotal role. So the thought process is if we can block IL-23 selectively, that we could have a large impact in treating inflammatory bowel disease. And certainly in psoriasis, which is another immune-mediated disease of the skin, and most of you probably recognize the name psoriasis, when this drug went into psoriasis, when this target went into psoriasis, it revolutionized the psoriasis world. So not only did they have standalone studies in psoriasis that showed that it was highly effective in the short and long term, but it went head to head against every other therapy that was being used in psoriasis, and in those what we call head to head studies, beat all of the previous drug therapies that were being used. So this drug, risankizumab or Stelara, or Skyrizi, I should say, is and drugs like it have really revolutionized psoriasis, where this thought of completely clearing the skin is something that is a reality. And so this has now been studied in Crohn's disease and was approved in the fall and is now available. So I want to highlight again, this is the first study that looked not only at getting patients better, but looking at endoscopy as an outcome. The drug is given intravenously during the induction phase over 12 weeks, and then it's given as a sub-Q injection every 8 weeks. And this is just the whole study design. What are the hallmarks of this drug? It works very quickly. Remember I said that that mucosal healing was something that we wanted to achieve sort of long-term out at a year. This can do it within 3 months. So not only does it met all of its endpoints, but it gets patients better quickly. It can heal the mucosa within 3 months. It can do it in patients who have never seen an advanced therapy like a biologic that we asked you about before. And it can do it in patients who've been on a biologic, such as an anti-TNF or, vedolizumab or Entyvio, and even though this is a cousin drug, even patients who've been on Stelara. And what we saw is that not only did it work quickly, but when we look at endoscopic response rates, especially in patients who've never been on an advanced therapy, about half of the patients could have what we call an endoscopic response, making those ugly bowels look at least 50% better. And about a third of them, if you've never been on a biologic, will actually be in remission by the end of 12 weeks. And if we look long-term, when patients go on to the injectables, it performs similarly. So you can see here this endoscopic remission, read this as mucosal healing. Half of the patients, right, who had never seen a biologic, were able to achieve that, and over a third. And remember, I said before, the drugs that we had, that we were only achieving those levels in about 25% of this bio-naive patient population. And it continues to work over time, and this is exquisitely safe. It really is tolerated quite well. And so for us as physicians, this is going to be a game changer. And the reason is because it delivers everything that we want for our patients in a drug that has a very, very high benefit to risk profile. And within the study, and this is probably the most important thing, because it got patients better so quickly within 3 months, including the endoscopic endpoints in the mucosal healing, if we look at those patients, by the end of the year, it had already made an impact compared to those patients on placebo in reducing rates of hospitalization and surgery. And so this is just an example of a patient within the trial. So this almost looks like that picture that I showed you before. This is when the patient came in, they were having significant symptoms. Their bowel looked angry and damaged. This is within the first 12 weeks of therapy. And this is what the bowel looked after 52 weeks. And this is what we should really be striving for you as our patients with inflammatory bowel disease. And if you do these complex statistical methods and you look at what the most effective therapies are that we've ever tested, this drug, if this drug and infliximab or Remicade and the biosimilars are the most effective drugs that we've ever tested. The other way to do this is when we really don't know, because there's so many things that can drive inflammation from outside the cell, these what we call cytokines, they all signal through a very common pathway, which is called the Janus kinase pathway. So, or what we call JAK inhibitors. So Janus is the Roman god of gates. So when we think about sort of signaling from outside inside the cell, it's like a gate. So it's in reference to Janus, the Roman god. So if we can block the gates to, that is telling and sending the message to the cell to be an angry cell and cause inflammation, we think that we can do better. So this is just a cartoon with that. And so this has been studied in ulcerative colitis. It's been approved in the United States last April and should be approved very shortly here in Canada. The hallmark of these therapies is they're oral therapies. So this is an oral pill that you take once a day. It works very, very quickly. Like it probably out of any therapies that have been studied, it works the quickest. It has onset of action similar to steroids, where many of my colleagues will be talking about perhaps we don't need to expose patients to steroids because this works so quickly. It also works in a large proportion of patients, meaning that, that after 8-week of therapy, almost 3/4 of the patients will actually be responding and half of them will be in remission. And this continues over the long term. This is just to show you how fast it works. If you have ulcerative colitis, this is having a stool frequency during a flare less than or equal to 1, rectal bleeding score of 0, so not noticing any blood anymore, and not having any bowel urgency that urge to go to the bathroom. So this is in green is the proportion of patients who achieve the endpoint. And you can see that within anywhere between 1 or 3 days, patients are actually having no diarrhea, no bleeding, and their urgency goes away. So when this does work in a proportion of patients within 2 weeks, about 50 to 60% of patients will have complete absence of these particular symptoms. And this is the endoscopic improvement. And what you can see, this is the long-term data. About 2/3 of the patients will have their bowel look much better. This is also been studied in Crohn's disease, and it'll be released this year, and similar effects for an oral pill in Crohn's. So this is the first oral advanced therapy for Crohn's disease. And again, it works across patients who've been never exposed to a biologic and to those who've been exposed to a biologic. And in Crohn's disease, it works very quickly as well. There's some side effect considerations with this that your doctor or your healthcare provider will talk to you about as well. This is just looking at the risk benefit. This is the benefit up here. There are some side effects, but again, they're not, they happen at very, very, very low rates. And so in the appropriate patient, the benefit to risk is very favorable for this as well. So I'm going to end. So mucosal healing is our ultimate disease-related goal. I think we need to use our toolbox, and that'll help us meet this goal in a timely manner. The reason is mucosal healing is associated with a number of important long-term outcomes. We need to introduce highly effective therapies early We need to make sure that we're controlling your disease and making sure you don't have inflammation by doing that tight control or that monitoring, and really escalating your therapies and or optimizing and switching them so that you can achieve mucosal healing. As mentioned in the beginning in the introduction, what I've said today is not a substitute for the discussion and the decisions you make with your own healthcare provider, but hopefully you've been educated and you can take some things home to help you guide your own personal therapy and journey with the disease. And with that, we'll go to the question and answers.
That's great. Thank you so much, Dr. Panaccione. That was a lot of information, and I'm sure there'll be many people watching the recording for a nice refresher. So there were tons of questions that actually came through during your talk. So I've sort of put those to the side, but we'll get started with the questions that were submitted ahead of time by all of you in the registration.
Yeah. So the first one is, which medications are recommended to treat frequent loose watery stools in IBD? So the way I'm going to answer this question is twofold. Number one is, whoever asked this question, I'm going to role play physician here, right? And you're my patient. So me and you are going to need to determine why you're having frequent loose and watery stools. And there's two main reasons. Number one is your IBD is not well controlled. So the inflammation and your gut mucosa being damaged is causing your loose watery stools. So if that's the case, you need better therapy to control the inflammation. On the other hand, there are instances where your disease is well controlled and you still have loose watery stools. And those fall into about 4 large buckets. Number one is it has nothing to do with the IBD, and it could be an infection, for example, including chronic infections. And there are some chronic infections that we have, like Giardia, for example, where you get from camping. Number two, it could be due to what we call small intestinal bacterial overgrowth. If you've had a surgery, especially in Crohn's disease, where your bacteria from your large intestine go into your small intestine, and that causes, and they're not supposed to be in that neighborhood, and that can cause symptoms, including diarrhea. So in those cases, do you have small intestinal bacterial overgrowth? And does that need to be treated? Number three is when you have a resection in Crohn's disease, depending on where, if you've had that surgery, it actually, there's certain substances, particularly bile acids, that are no longer absorbed properly because you've lost that segment of your intestine. And because of that, you need something to combat that. And there's certain strategies. So do you have bile acid diarrhea? And finally, there is an overlap in maybe up to 40% of patients where you could have superimposed what we call irritable bowel syndrome on top of IBD. So how do we determine that? Well, if you're on a therapy for your IBD and your inflammation is controlled, and we know that your biomarkers are normal, we've done x-rays, everything looks, it could be that you have irritable bowel syndrome, and there's a strategy for that. So the first thing is to ask the question, why? And then which medications is really depending on the answer to the why, and your healthcare provider can probably help you with that.
Oh, great. Thank you. Next question, please. Great. How can gut healing be promoted through diet and nutrition?
Yeah, and this is a great question. So thank you for whoever submitted this. So with the evidence that we have at this moment, there's no particular diet that has ever been associated with sort of healing the gut. You'll read a lot of things online, and part of the reason is just because it likely has to do with what I said before about trying to control inflammation. A good friend of mine, for example, named Jim Lewis, from the University of Pennsylvania just did this brilliant study of diet intervention, well-controlled and everything. And what did that show? It showed that patients symptomatically got better on the diet that was being used compared to if you were placebo. What it didn't show, those markers of inflammation, or if you looked in, didn't change at all, despite the symptoms getting better. And that's probably the most the sort of the most modern study looking at this. Now, that does not mean that you shouldn't use diet to help you control your symptoms, or as an adjunct strategy with your healthcare provider to sort of promote healthy living, because I completely believe in that. But trying to use just diet alone, right, to try to promote gut healing, unfortunately, has never been shown.
Thank you. And related to this, there was a question through the chat. So in addition to, I guess, as you mentioned, diet alone may not necessarily be able to be used to promote mucosal healing and reduce inflammation, but are there any other sorts of lifestyle factors that could be used to promote mucosal healing beyond medications?
Not on its own, and not in what we call adjuncts. So where there's a lot of interest in research, and there's a group of us from around the world who actually discussed this morning on an early morning call, is diet and lifestyle changes are probably, again, in that environment sort of piece, right? And what we probably need to do is control the inflammation with again, like some sort of drug therapy, hate to say that, and use diet and nutrition and lifestyle changes as an adjunct to even get better than the drugs alone. So what we're trying to do is to develop strategies where we say, okay, where we're going to do is use a highly effective therapy alone in one group, and use highly effective therapy and say a particular diet in another group, to see if the diet adds anything to the limitations of our therapy. And that's not only goes with diet and nutrition, but other sort of lifestyle changes.
Thank you. Next question, please. Are there any supplements? So, you spoke to this a little bit, but if you want to elaborate.
And this is the same thing. And this is a little different because there are some, depending on what the supplement is. So, for example, if you think of curcumin as a supplement, which you can get curcumin tablets or pills, there is evidence for curcumin, but that's more of its anti-inflammatory type effects that it has, that it's controlling inflammation, then that's controlling mucosal, and that's leading to mucosal healing. So the supplement thing is also interesting. Curcumin would be probably the prime example in ulcerative colitis right now. So that can probably help you. Again, I don't want that to be taken as take curcumin alone and stop your other therapies, but as a supplement, that would be an example where it could help promote gut mucosal healing.
Okay, thank you. And what about like digestive enzymes, probiotics? There were a few people that asked about that as well.
Yeah, so digestive enzymes, for example, the way they probably help, they help in the short term when your mucosa, because mucosa is damaged, to help you digest your food, or if your mucosa has been repeatedly damaged and never gets back to its normal functioning, some patients will benefit from digestive enzymes. And then the other thing is that some patients with inflammatory bowel disease can have their pancreas, which is another organ that helps with digestion. It may not work as well as it should because of chronic inflammation, and digestive enzymes can work there. The probiotic part of it, probiotics have been studied extensively. We've studied them in a few randomized controlled trials. They fall into that bucket of can make your symptoms better, but probably don't make your disease better. So what probiotics do is they rebalance in patients who have what we call dysbiosis. That can be due to inflammation, could be due to certain surgeries, can be due to motility. They tend to sort of rebalance the environment in your gut, so your gut is happier and you don't get as much bloating and sometimes diarrhea and cramping.
Thank you. And for those of you that are maybe interested in supplements, we mentioned that in May, we have our next Gutsy Learning series, which we'll talk about curcumin and some of the other therapies as well. So join for that if you're interested. Next question, please. Do healthcare providers prescribe medications used to treat IBD in a specific order? This is a great question.
This is a wonderful, wonderful question. And maybe if I can have the liberty, you meet other IBD patients and they're on a variety of medications, right? And you probably scratch your head as why is Jane on this medication and why is Joe on this medication? We both have Crohn's disease, but we're on different medications. The simple answer here is no, because making decisions regarding what type of medication a patient goes on is complex. It depends on what disease you have, Crohn's or ulcerative colitis, where the disease is, how severe or aggressive the disease is, but most importantly, like I said in the talk, we don't know which one is going to work for an individual patient. Is what are the goals of the therapy and what are the important patient values that patients want to see in their therapy? And those values are different for individual patients. Some patients put a lot of value in the way a drug is administered or a therapy is administered. Some patients put a lot of value on the experience that a physician has with a particular therapy. Some patients are more concerned with safety, for example, and there's maybe a perception that one therapy is safer than another. So all of those come into play. Now, as a physician, do I believe that there's certain therapies in 2023 that are more effective than other therapies given the evidence? The answer is yes. And so when I'm going to get into this discussion with my patients, whether it's a first line or second line, then I will have a specific order in my own mind, but that never supersedes what the values are of the patient. It's all about patient education. I can guide them, right? But as I always tell my patients is the most important thing is to make a decision and intervene early. And if that decision is not the right decision from the perspective of getting you better, then we need to agree as a team that we're going to pivot to something that will get you better. But the starting point can always be left up to the patient. There's very few times where I always say I'm paternal and I'm like, no, we're using this drug. I'll tell you why. Okay.
Yeah, that's fair. I think this question might have been asked also because some comments here that are coming through are that depending on the provincial payer, some medications won't be able to be covered if they do not take certain medications first, like that kind of step up approach.
And that's a great call out, Sarah, and thank you for pointing that out, or if someone pointed that out in the question and answer or chat. And it's absolutely correct, is that certain drugs are actually not even available in certain provinces just because of the approval process. It is quite frustrating when there are certain limitations on what we can prescribe, but there's always ways to talk to your healthcare provider on how to maybe navigate that more complex world.
Okay, thank you. And I'm just being mindful of the time here. We're almost at 8:30 Eastern time. So I think I'll head over to a question in the chat for the last one. It's specifically about Skyrizi. Has it been studied in children or teens? affected by IBD. I'm not sure if this was mentioned.
Yeah, and so the studies, are in individuals who are 18 and older. Actually, I think there's a smattering of 16-year-olds in there, but not in children less than adolescent age. And that's the case usually. So meaning that the pediatric studies don't usually happen for several years after, or reported until several years after the adult data. The drug, I know that the drug has been used in the pediatric. And so if you're, a parent of a child, I think that, you can discuss this with your healthcare providers. Over the years, a lot of the therapies that we've mentioned this evening have been used in the pediatric population before the trials actually came out. The most important thing is always to think about the safety of the children, right? And so, again, it warrants a discussion with your healthcare provider. If this is an off-label, what we call off-label, would I have any concerns using Skyrizi in a pediatric aged patient? The answer would be no. And certainly I know my colleagues who run big pediatric IBD centers in the United States have used Skyrizi in kids.
Okay, thank you. So would it be available for, like, if a caregiver?
It's usually available in a compassionate nature.
Sure.
It's a discussion between the healthcare provider and and the manufacturer of the product.
Okay, fair enough. Okay, well, I think that's all the time that we have for questions. Again, thank you so much, Dr. Panaccione, for being with us here, sharing lots and lots of valuable information I'm sure people will take away to discuss with their healthcare providers in their future appointments. So again, if your question wasn't answered and we weren't able to get to it, please do email us at learn@crohnsandcolitis.ca. We can follow up with you directly there and get your questions answered.
Thanks, everyone.
And thanks very much, Dr. Panaccione. And to end the webinar, I'd like to do the poll just one more time, just to see where people are landing now with their knowledge with respect to medications used to treat Crohn's disease and ulcerative colitis now that we've had the webinar take place. So I'll give everyone a few seconds to provide your responses. Okay, let's take a look. Okay, definitely a shift more towards feeling more knowledgeable and probably confident. So thank you again, Dr. Panaccione, very much.
Thank you, everyone. Okay, have a nice evening. Bye-bye.
Take care. And before we end, I'll just do a quick plug in here for our IBD AbbVie IBD scholarship. So if you or someone you know is affected by Crohn's disease or ulcerative colitis and is pursuing higher education in secondary school, post-secondary school, then we do encourage you to apply for one of our scholarships. There are 15 one-time scholarships valued at $5,000 each. And the deadline to apply is May 15th. So make sure that you get your application in by the deadline and don't let this opportunity pass you by if you or someone you know may be eligible. And you can find out more information on our website as well for that. And Crohn's and Colitis Canada is also offering, again, summer camps this year as part of our Camp Got to Go program. And this is really another great opportunity for children and teens that are affected by these diseases to meet with others, again, know what it's like to live with IBD. And there's lots of fun activities. It is an overnight camp. So if you would like to learn more about this and the different various locations in Eastern, Central, and Western Canada, please visit our website, crohnsandcolitis.ca/camp, or you can scan the QR code as well on the screen here. And as always, we love to get your feedback. We take a look at every response that's provided to try to improve on future webinars. So you will see a survey pop up on your screen when you go to close Zoom. It should only take you 60 seconds, and we'd really greatly appreciate your participation in providing that feedback. So thank you for your time in doing that. And finally, a special thanks to BG Communications for providing the live French interpretation for the webinar this evening. If you don't already follow us, You can follow us on various social media channels at Get Gutsy Canada. Thanks again, everyone, for joining us this evening. And a reminder that a recording of this presentation will be emailed to you and available on our website at crohnsandcolitis.ca/GLS or on our YouTube channel at Get Gutsy. Thanks very much, and I hope you all enjoy the rest of your evening.